Hello, this slide set is about glomerulonephritis. As you can tell by the term, it refers to an inflammation of the glomerular part of the kidney. Whenever you see ITIS, you think inflammation. And this unit is about adaptive immunity. So glomerulonephritis, for the most part, the glomerulonephritis is caused by adaptive immune issues. There are many glomerular disorders called glomerulopathies, and they're disorders that directly affect the glomerulus, which is part of the kidney. They could be primary or they could be secondary, coming from some other disorder. And glomerulopathies are a significant cause of chronic kidney disease and end-stage renal failure worldwide. So that's why it's important to talk about this. So let's review a little bit of renal anatomy. So this is a picture of the kidney. You can see on the top left is the kidney, and then to the right it breaks out into the units of the kidney, which are the nephrons. And you can see all of the different nephrons. And then below that you can see an individual nephron, and below that you can see an individual glomerulus. So the glomerulus is the end of the nephron where there is the afferent arteriole, which brings blood into the kidney, circulates around, and then comes out the efferent arteriole. And then through this capsular membrane here, fluid filters through and eventually becomes urine. So this is a picture that looks at a cross section of the glomerulus, so that you can see some of the different key areas that are affected by glomerulonephropathies. And I found this picture a little bit hard to see, so I made my own drawing. So let me back up. So this is, as you can see in here, there's 4 different blood vessels, because there are several different vessels down in here in the glomerulus. So when you do a cross section, you can see there's 4 vessels. In the center of that is the mesangial area. In my picture, and then the basement membrane goes around all of the 4 vessels. So in my picture, we're just looking at one of those blood vessels, okay? Just to orient you. So you can see on the outside is the Bowman's capsule, and these little green cells are the epithelium that line the Bowman's capsule. And then in yellow, appropriate color, is the urinary space. So that's where the filtration begins that will eventually become urine. These little blue cells that you see on the outside of the capillary are epithelial cells. They're also called podocytes because they have little legs, as you can see. They kind of stick on to the outside of the lumen. Then there is the basement membrane, or the glomerular basement membrane, and that goes around all of the vessels. And then inside is the capillary lumen, and you see there's endothelial cells. We're familiar with endothelial cells lining the inside of blood vessels because we studied that in the last unit. And of course inside is the capillary lumen, and I've drawn some little white blood cells, red blood cells, proteins, etc. And then in the center of where all 4 of the blood vessels surround is the mesangial matrix, and you can see there is a mesangial cell. So that's just a little bit of anatomy of what the glomerulus looks like. And I'm not going to spend a lot of time on this because this is really a review of basic anatomy and physiology. If this is really unclear to you, you might need to go back and review it. But this is the mechanism of urine formation. So the blood comes in the afferent arteriole, circulates through the glomerulus, and molecules filtrate out into the urinary space, and then the blood leaves through the efferent arteriole. And just point out that the afferent and efferent, where you might run into problems, okay? So let's say that there is a constriction of the afferent arteriole. For example, maybe a patient is in shock, so the blood is not getting to the afferent arteriole. Then you're going to have a decrease in the glomerular filtration rate because the blood can't get through. If you've got constriction in the efferent arteriole, that's also going to slow things down because the blood can't get back out, so it's going to be kind of stuck in there. So those are just important things to recognize. So after the blood leaves the efferent arteriole, there are capillaries that surround this tubule here. And the tubule is where the urine filtrate goes. And you know that, remember that there's the proximal tubule, the loop of Henle, and the distal tubule, and then it eventually collects in the collecting duct, which ends up in the ureter. But these blood vessels surround the tubule, so there's constant exchange of molecules all along the way. And there's different parts of the tubule where different types of molecules are exchanged. Mostly you're looking at potassium, water, and other molecules. Amino acids, glucose, sodium also are exchanged. And then antidiuretic hormone is important in reabsorbing water. Okay, so let's talk about acute glomerulonephritis. So glomerulonephritis can be either acute or chronic. So we're going to start with acute. So there are three different types of adaptive immune responses that can lead to acute glomerulonephritis. The first one is a type 3 hypersensitivity reaction. We talked about that last week. And this is the most common type. And this is, in this situation, immune complexes, which is an antibody and antigen that meet each other. They form in the circulation and then they're deposited in the glomerulus. It can also occur in situ. In other words, the antigen deposits in the glomerulus, and then the antibody finds it, and then they form the complex there. Okay? A type 2 response is a tissue-specific reaction. And in this situation, the antibodies are reacting not to a foreign antigen, but to glomerular basement membrane tissue that it sees as foreign. So it's not like a bacteria has lodged in the glomerulus and the antibody attaches to it. It's reacting to the body's own tissue. And this is the least common. Type 4 is a cell-mediated reaction, and that's when it involves T cells. So no matter which type of reaction occurs, you really get the same response. You get that inflammatory response that we've been talking about for the last 4 weeks. You get activation of complement, chemotaxis, which is drawing white blood cells to the area, phagocytosis, where the white blood cells try to destroy whatever they see as foreign, the release of lysosomes and toxic reactive oxygen species, or ROS, into the tissue. And this causes damage to the tissue. There's also natural killer cells that damage. In the case of type 4 reaction, it's the T cells that are directly destroying tissue. And all of this results in injury to the glomerular filtration membrane so that it's not working properly. So the results of this tissue injury are that you lose negative charges, and the negative charges are what keeps the proteins in the bloodstream. And when you lose that negative charge, it allows the proteins to escape. The other thing that allows the proteins to escape is increased membrane permeability. Also, the basement membrane gets thickened and scarred. There's a decrease in surface area, so there's less area for exchange to occur. That extracellular matrix expands into the Bowman space and takes up space that is normally needed for filtration. And in some cases, there are deposits of crescent-shaped substances into the Bowman space. So the overall result is that you get a decrease in your glomerular filtration rate. And that is important. The GFR is an important number that tells us how the kidneys are functioning. If not enough fluid or not enough filtration is occurring, then the kidneys are not able to clear toxins. Okay, so what happens is the glomerular blood flow is slowed because of inflammation, because of scarring, and because of thickening of the basement membrane. So what is the etiology? Why does this occur? It can be infectious or non-infectious. One type of infectious glomerulonephritis comes from streptococcal infections, and it can also come from non-streptococcal post-infectious glomerulonephritis, and these can be bacterial, viral, or parasitic. So in these cases, there's a reaction between an antibody and an antigen, and there's a deposition of that either deposit, or it's either the reaction occurs systemically and then it deposits in the glomerulus, or the interaction occurs in the glomerulus itself. And then that's that first reaction that we talked about, the type 3. It can also be non-infectious, and these can be either from a secondary or primary disorder. Diabetes and lupus are common causes of a non-infectious glomerulonephritis. There also are primary glomerular diseases that can lead to glomerulonephritis. This is just a little cartoon of post-streptococcal acute glomerulonephritis. So on the left, you see there's an antigen, which is group A, beta hemolytic strep, and in the body forms an antibody-antigen complex in the systemic circulation, and then it's deposited into the glomerulus. And that antigen-antibody complex leads to an increased production of epithelial cells that line the glomerulus. Then leukocytes infiltrate. The glomerular filtration membrane thickens. There's scarring and loss of the filtration membrane, and then decreased glomerular filtration rate. So that's the pathophysiology. This is kind of a little cartoon of what you see. You can see that antigen-antibody complex is in the glomerulus. These are some of the symptoms that people have with this: headache, high blood pressure, periorbital edema, malaise, low-grade fever, weight gain, proteinuria, hematuria, and sometimes oliguria. So another type of nephropathy comes from IgA, or immunoglobulin A disease. It's also called Buerger's disease. This is the most common form of idiopathic acute glomerulonephritis. Idiopathic meaning that the etiology is not really clear. So it's not like we can say it comes from post-strep. It's idiopathic. It affects children and young adults, and there is an abnormal IgA that binds to the mesangial cells. Let me see if I have a picture. Oh, I do. Here's a picture. On the left is a normal blood vessel in the glomerulus, and on the right you can see with IgA these mesangial cells proliferate and start to move in and block. You can see they're pressing on this vessel and making it smaller, so there's a smaller space for filtration to occur, and the little black blobs are the IgA. So this can be reversible. Usually it occurs about 24 to 48 hours after a URI or viral gastroenteritis. You'll see proteinuria, hypertension, and edema in more severe cases. And 20 to 40% will progress to renal failure. And anybody who has this needs long-term follow-up. They need to be seen every 6 months and have their urine checked, their blood pressure checked. So what to remember about IgA nephropathy is that it's called Buerger's disease. Buerger disease. It affects children and young adults, and it has to do with an abnormal IgA, but it occurs 24 to 48 hours after a URI or viral gastroenteritis. There's another disease called Henoch-Schönlein purpura nephritis, and this is also called anaphylactoid purpura. This is a form of IgA glomerulonephritis. But along with the renal manifestations, there's also purpura, arthritis, and abdominal pain. And this also occurs in children. The most common cause of acute glomerulonephritis is membranous nephropathy, and this is from circulating antibodies that are either deposited or they're formed in situ on the podocytes, and those are those little cells that epithelial cells that surround the basement membrane, and it also can be come from hepatitis, lupus, drugs, and some cancers can cause this. And the results can be proteinuria and nephrotic syndrome. And we'll talk a little bit about nephrotic syndrome. So this is a picture, again, to remind you where the podocytes are, these blue cells that surround the basement membrane are the podocytes. So in membranous nephropathy, it affects the cells surrounding the basement membrane. And again, this is the most common cause of acute glomerulonephritis, so that's something to remember. Then there's a type that's called rapidly progressive. It's also called crescent glomerulonephritis. It can be idiopathic. It can also come from post-strep or lupus. This mostly affects adults, and this is antibodies against the glomerular basement membrane. So this would be considered a type 2. It progresses to renal failure in weeks, so that's why it's important to recognize this. If it's not diagnosed and treated early, the prognosis is poor. Then there's a type called mesangial proliferative, where immune complexes are formed in the mesangial matrix, and there's proliferation of mesangial cells. So again, this is what we saw in the IgA nephropathy. It can also be caused by lupus or diabetic nephropathy. And the last is membranoproliferative. You don't need to know this because it's rare. And this is just a picture of what it looks like. So hemolytic uremic syndrome is important to know because this is the most common cause of acute renal failure in children. Most of these occur in children younger than 4, so pretty young kids, and it's associated with a bacterial or viral infection. Bacterial toxin from E. coli can cause this. And what happens is the arterioles of the glomerulus become swollen and occluded with fibrin clots. So obviously, if there's occlusion of the vessels, you get a decrease in your glomerular filtration rate. There's also hematuria and proteinuria from the inflammation. The red blood cells are damaged because they're trying to get through a narrowed vessel. So the spleen removes those damaged red blood cells, and that causes acute hemolytic anemia. So whenever you have any kind of disease that causes damage to blood cells, the spleen will filter them out, and then that's when you get acute hemolytic anemia. So the microcirculation also develops thrombi. Manifestations, usually there's a prodromal GI illness with diarrhea, sudden onset of pallor, bruising or purpura, irritability and oliguria, and then it can lead to renal failure. So the treatment is to maintain nutrition and hydration, to dilute the toxins, control hypertension, hyperkalemia, and seizures. When renal failure occurs, treat with dialysis. Blood transfusions are needed, and most children do recover. An important thing for you to know is that a child with a prodromal GI illness with diarrhea that comes in with bruising and purpura, think about this. and then they would need to be hospitalized. It can be sudden or insidious. It may be silent, mild, moderate, or severe. The two major symptoms are hematuria and proteinuria. And if it's severe, they may have oliguria, hypertension, and renal failure. So these are some diagnostic tests that might be done for glomerulonephritis. You're going to be getting a CBC. You want to look for a possible anemia, leukocytosis, left shift, and increasing SED rate. So an increasing SED rate or C-reactive protein are both signs of inflammation. Anemia may come from what we just talked about, the hemolytic uremic syndrome, where the red blood cells are being damaged. Leukocytosis and a left shift would show that there's an infectious process. And then your basic chemistries, you're going to get a BUN and creatinine, obviously, because those are the two signs of renal insufficiency and renal failure. You're going to be looking at total protein and albumin, because if you're losing protein in the urine, then you're going to have a low protein and albumin in the blood. Looking at serum electrolytes, because we know that the kidney plays an important role in maintaining electrolyte balance. Cholesterol, and we'll talk about that in a minute. Functional state of the liver. And then you're going to examine the urine, looking for red blood cells, red cell casts, proteinuria. And we'll talk a little bit more about what the urine looks like in different conditions. And then an ASO titer, because if this is a post-streptococcal glomerulonephritis, you're going to have a positive ASO titer. And then sometimes a kidney scan or biopsy is warranted. So treatment really depends on the severity and the underlying process. If there's an infectious process, you're going to be treating with antimicrobial therapy, and this is to control the symptoms and prevent the infection from spreading. Doesn't appear to prevent the development of glomerulonephritis except if given within the first 36 hours. Loop diuretic therapy may be given for the edema. ACE inhibitors, angiotensin II receptor agonists, statins for treating high blood pressure and lipid abnormalities, vasodilator drugs if there's severe hypertension, immunosuppressive agents in some situations, and anticoagulants may be given if they're in rapidly progressive situations. Okay, so the terms nephrotic and nephritic are used, and I wanted to talk a little bit about what the difference is. So when you have acute glomerulonephritis, the way it manifests may be nephrotic, nephritic, or both. So the urine sediment may be nephrotic or nephritic. Nephrotic urine sediment mostly contains proteins and lipids in massive amounts, and microscopic amount of blood or no blood. Nephritic is mostly blood. You'll see red blood cell casts and white blood cell casts. Varying degrees of protein, not usually severe. So nephrotic protein, nephritic blood. Whenever you see the word cast in urine, always think this is renal. Okay? If you see red blood cells in the urine, that could be coming from a urinary infection. It could be coming from bladder cancer. If you see red cell casts, it's coming from the kidney. Same with white cell casts. Any kind of casts are renal. Why? Well, we'll talk about this in a minute. This is just some pictures of different urines. So number 1 is normal. Number 2, maybe a little bit of protein in microhematuria. 3, some protein in hematuria. And 4, visible hematuria and a high level of protein. So nephrotic syndrome, like we said, nephrotic syndrome is primarily there's protein. So you have protein in the urine, and because you have all this protein spilling out in the urine, you've got low albumin. Why high lipids? Because the body is trying to compensate for this low albumin by the liver producing more lipoproteins, and that elevates the lipids. Then you get edema. Okay, and the edema comes from the hypoalbuminemia. So nephrotic syndrome may be primary or secondary. Primary is idiopathic, and one type is called minimal change nephropathy, membranous and membranoproliferative glomerulonephritis, which we talked about, and focal segmental glomerulonephritis. You don't need to know all of these, but you just know that it can be primary or secondary. Secondary nephrotic syndrome, you should be able to know that this is caused by either diabetes, lupus, that IgA nephropathy or Berger disease that we talked about. It can also be caused by drugs, malignancies, and vascular disorders. Congenital is an autosomal recessive that's usually expressed in the first 3 to 12 months of life. So in nephrotic syndrome, what happens? You have an injury to the basement membrane, increased permeability, loss of protein or albumin, hypoalbuminemia, release of inflammatory mediators. So we get white blood cells coming in, and this leads to sclerosis and fibrosis. And as I mentioned, when you lose albumin, it stimulates the liver to produce lipoproteins, so you get elevated lipids. And as the proteins leak out, a lot of those proteins are immunoglobulins, so that increases the susceptibility to infection. And then sodium retention leads to edema. So the edema comes from both the sodium retention and the hypoalbuminemia. And this is just a little picture. Some people like these kind of pictures. It helps you to see it, so we'll go over that. So you have altered glomerular permeability and loss of negative charge. We talked about that earlier. And that allows the plasma proteins to leak out, so you get protein in the urine. Loss of transport proteins, so you're going to decrease your vitamin D and decrease thyroxine, because those both need proteins. And on the right side, you're going to get a decrease in your immune globulins, so susceptibility to infection. Hypoalbuminemia causes the liver to synthesize lipoproteins, so you get high protein in the blood, and then you get high lipids in the blood, and then you get lipids leaking out through the urine. Hypoalbuminemia also causes a decrease in your plasma oncotic pressure, decrease in the plasma volume, and that the body reacts by the renin-angiotensin-aldosterone system. So you get an increase in anti-diuretic hormone, so the body begins to retain sodium in water. Okay, so that leads to edema. So what you see is edema, and I have down here in bold, periorbital edema is often the first clinical manifestation. So when you see somebody, especially a child, but an adult with periorbital edema, always think nephrotic syndrome, okay? So you have low protein, sodium retention, water retention, increased activity of aldosterone and antidiuretic hormone, a decrease in the atrial natriuretic peptide, and so you get the periorbital edema in the morning, and then the edema shifts to the lower extremities and abdomen as the day wears on. And here's a picture of a little child with periorbital edema and nephrotic syndrome, and you can see the scrotal edema as well as abdominal distension from ascites. And then the hyperlipidemia. You also have hypercoagulation, so you're at risk for thrombosis, and this comes from abnormalities in the coagulation pathways. The urine may be decreased or frothy or foamy. Also may be associated diarrhea, anorexia, and poor absorption. So the treatment really is focused on trying to reduce the excretion of protein and maintain a protein-free urine. So you also want to prevent or treat any kind of underlying process going on, just such as an infection. Glucocorticosteroids, such as prednisone, maintaining a low sodium, well-balanced diet, skin care. If edema is a problem, you may give diuretic agents, ACE inhibitors, non-corticosteroidal immunosuppressive agents, and glucocorticoids are not effective in infants. And somebody with nephrotic syndrome, you will be consulting with somebody. It's not something you will be managing on your own right out the gate. Now, maybe after years of experience, if you're comfortable with it, you may manage it on your own. But this would be something that you would be definitely contacting your supervising physician to help manage, or sending the person to a nephrologist. Nephritic syndrome. Okay, so nephritic syndrome, as we said, is characterized by hematuria with red blood cell casts. There's maybe proteinuria, but it's not severe. You may have hypertension, uremia, and oliguria, and these can co-occur, so it's not always clear. And this can be associated with infections, with rapidly progressive, meningeal proliferative, IgA nephropathy, lupus, and diabetic. So basically, it's not like diabetes always leads to nephrotic and this always leads to nephritic. They can lead to both. Okay, so because we see lupus, diabetes, and IgA nephropathy are under both. Okay, the symptoms and treatment are similar as for nephrotic. So with that being said, I'm not sure why we make such a big deal about nephrotic versus nephritic, but it's important for you to know those terms. But what I would really want you to get out of this is the manifestations, the underlying pathophysiology, and then what kind of diseases they're associated with. So you need to know that it can be post-infectious. It can come from an IgA nephropathy, it can come from lupus, diabetes, etc. All right, now let's talk about chronic glomerulonephritis for a few minutes. So this is when you have a glomerular disease that's progressive and it leads to chronic kidney failure. Diabetes and lupus are the most common secondary causes of chronic glomerulonephritis. And chronic glomerulonephritis usually starts with acute glomerulonephritis. Not always. Sometimes it can just be a slow progressive, but acute glomerulonephritis that does not resolve will become chronic glomerulonephritis. So for someone with diabetes or lupus, the onset may be 10 or 20 years after the diagnosis of the lupus or diabetes. And it usually begins with renal insufficiency, and then it progresses to nephrotic syndrome, and then rapidly progresses to end-stage renal disease. Corticosteroids are not effective for diabetes. Usually they will need dialysis or transplant. Now, corticosteroids may be used in lupus. So diabetic nephropathy, why does this occur? Well, chronic hyperglycemia, it causes it, and the complications from chronic hyperglycemia include metabolic, inflammatory, and microvascular. So all three of those lead to diabetic nephropathy. You get changes in the epithelial cells, and those are those podocytes that surround the basement membrane, thickening and fibrosis of the basement membrane, and then expansion of that mesangial matrix. So diabetic nephropathy is the most common cause of chronic kidney disease and end-stage renal failure. That's a good thing to remember. That may show up on your test. Lupus nephritis is a little different than diabetes. It's caused by autoantibodies against DNA and nucleosomes. So there are immune complexes that are deposited in the glomerulus. This causes activation of complement and the inflammatory cascade that we've talked about, and this leads to damage to the glomerular membrane and expansion of the mesangial cells. And the manifestation is usually nephrotic syndrome. And the treatment is immunosuppressive agents versus diabetes that does not respond to those. So what you'll see in the urine sediment in chronic glomerulonephritis, we talked about acute when you see the red blood cell cast, white blood cell cast, and nephritic syndrome. In chronic glomerulonephritis, you see waxy casts and granular casts. Less protein in blood than you see in the nephrotic and nephritic sediments. So kidney dysfunction, we'll talk about this more in the slide set on renal failure, but it can be acute or chronic. It can be reversible or irreversible. You can have renal insufficiency, renal failure, and end-stage renal failure. And end-stage renal failure, you have less than 10% of the renal function. And that's the end.